Okay, I think we're getting everybody in here. All right, perfect. I think it is 12:01, so I'll go ahead and do the introduction. Hello, everyone, and thank you for joining us today. We're especially grateful to have you back with Burrows Consulting for another valuable session. Before we dive in, I'm excited to introduce today's presenter, Charles James, President and CEO of North American Healthcare Management Services. Many of you, including myself, have had the pleasure of learning from Charles through his insightful billing webinars and his educational work with NARC, the National Association of Rural Health Clinics, among many other organizations. So without further ado, I won't keep us waiting any longer. Charles, the floor is yours.
Great. Thank you very much. I think my screen is shared and you should be able to see me.
Looks
So
good.
great. Well, thank you for the kind introduction and the invitation to be with you once again. Indeed, I've been traveling to a lot of state associations. I'm going to Kentucky tomorrow. So it's always an effort to stay up to date and keep track of what is or is not happening for us in rural health clinics. So thanks again for having me. We're well into 2025 at this point. We did have a number of updates, new benefits, other developments that have taken effect in 2025. Many of these updates, as you may or may not know, did not take effect until just the end of July. So a lot of these were phased in, and we're going to talk about all of those. So we've had corresponding to the final rule developments that we had. We have an updated Medicare, still can't say that, Medicare Benefit Policy Manual, Chapter 13. So now all of the things I'm about to talk about, many of them are contained in that Medicare Benefit Policy Manual. And that, as always, is kind of our Bible for all things we're doing rural health. We're going to talk about telehealth. We're going to talk about care coordination services. Definitely some big updates there. Remote monitoring goes into that. Add-on codes, CPT2 codes, how we're billing flu and pneumo, and some productivity reporting. And I don't have on this list a couple of our conditions for participation that have changed. So how these get released is we get Code of Federal Regulation updates. Ultimately, we get a Medicare Benefit Policy Manual update that talks about the regulatory changes that have been enacted. And as always, if I've done this right, that should be linked on these slides. I'm sure Melissa will send these out after we're done. And be sure and go look up things we're talking about in the Medicare Benefit Policy Manual. You'll see a lot of red in the current version. So all of our updates, Medicare physician fee schedule, final rules typically come out at the end of a given calendar year. So when we talk about 2025 physician fee schedule updates, those were released in November, and then we get a hold of them depending on their effective date during the course of our calendar year. This is where you can find some of these. These are linked on the slides. And as always, there's a lot of information buried in these final rule updates. So,
Olive woman, excellent.
So let's.
Oh, if we could mute. There we go.
So there's a lot in these for just rural health clinics. There's a lot in this for the whole rest of the world. Being able to distill down what's relevant to us is a bit of a trick, but that's also why we're here today. So some of our updates are also contained in the hospital outpatient final rule and not necessarily in the Medicare physician fee schedule final rule. And if you really have insomnia sometime, just go out and read through these. Look at the list of things that are contained in this final rule. We have care coordination updates, where we've unbundled G0511. We have a new care management benefit for advanced primary care management, which is a care management service. We have an extension for G2025 once again. We keep kicking that can down the road. We've changed how preventive vaccines are going to be paid in our rural health clinic, and we've eliminated RHC productivity standards. Some clarification on dental, rebasing FQHC market basket, conditions for certification, as I mentioned. We have hemoglobin, hematocrit, occult blood removed from our RHC requirements. We have a clarification on primary care services and intensive outpatient program services. So rural health clinic, remember, is a statute. I'm always reluctant to use this word statutorily. It's not the cleanest word in the world, but remember our rural health clinic provisions are all based on the original law, the statute that was created by Congress in 1977. And in that, the law requires that we are primarily engaged in furnishing outpatient services, and we are not a rehab or primarily behavioral health treatment center. So that's very important. And that is one of the things that changed in all of our Federal Register updates. So bear with me, we'll get to that behavioral health clarification at the end of this presentation. One of the biggest questions that we always get is, what is the status of telehealth? What's the status of G2025? I try to go to every lobbying gig I can in Washington, D.C., and talk to our legislators on a grassroots effort to remind folks that we are rural health clinics. We still need consideration. And with telehealth, we need to stop kicking the can down the road. Remember, our current ability to bill telehealth as a distant site at the clinic or originating site where the provider or the patient is, were all created. Our G2025 were created by COVID telehealth flexibilities that are now, of course, 5 years old. I think, and I need to go look, I believe that my December 31st date is wrong here. I believe that our current telehealth flexibilities right now go through September 30th, and that's our G2025 billing that waives all of the originating site, distant site restriction that we had pre-COVID. So G2025 goes right along with that. The ability to bill the patient's home as an originating site and use telephone only for telehealth is currently in place. Scratch that, and is right now through September 30th. And frankly, it's changed so many times, and I'm questioning myself right now whether or not September 30th, December 31st, it's gone back and forth. The original final rule said December 31st, and then the actual Budget Reconciliation Act was passed at the end of, or right at the beginning of this year, which set it back to September 30th. And so it just keeps going back and forth. So the thing to know is right now, we still have those flexibilities in place. And whenever we go talk to Congress members, Congress people and senators about this, they say, oh yeah, we want to do something about this. I'm going to stop kicking the can down the road is the term everyone uses, except no one's made it permanent. I'm sure you've heard of some of the goings on in Washington right now, and there's a great deal of change in the air, and we just get deprioritized is what happens. So right now, COVID telehealth flexibilities are still in place. Remember, however, my next slide, this gives us our G2025 flexibility, which includes that audio only component. Includes the audio only, so telephone only is part of our COVID telehealth flexibility. Remember that G2025 is not an encounter-based payment. It is the national average of all 270 some odd services that can be performed via telehealth. It's the national average of those. And so that's where we get to our dollar amount. And gosh, I'm reluctant to say it. I said $95 right now. We're going to see where we can go find that. But that, remember, is a non-encounter based service. So right now, a telehealth encounter does not go into your cost report. Part of the expectation is that we want telehealth as encounters. However, when that happens, a lot of us are going to start having problems with our rate, because if we're doing a lot of telehealth, once they're counted as encounters, they go into our cost report. And we've been able to save a lot of rates because right now we're pulling telehealth visits out of our our AIR calculation, and the same with some of the associated costs. So just remember, that's a non-encounter based payment. And part of our telehealth flexibility is permanent. Mental health as a face-to-face encounter, or an encounter performed via interactive real-time audio video telecommunications, or telephone only, right now is a defined visit. What does that mean? That means our statute was changed, 405-2463. Statute got changed to make permanent behavioral health via telehealth as an encounter. So if you have LCSWs, if you have clinical psychologists performing telehealth, their encounters do go into our cost report. They're paid as an encounter. That part is permanent. It doesn't have anything to do with G2025. So G2025 is for now clinical, medically necessary, non-behavioral health visits. And our behavioral health visits get billed and paid as encounters. So remember, when behavioral health telehealth visits were enacted, the in-person visit requirement, there is an in-person visit requirement for behavioral health telehealth that says the patient will come to the clinic once per year and be seen in person, or to establish telehealth for our behavioral health patients requires an in-person visit first. That was all waived when this first came out. It's now been maybe 3 years ago. The in-person visit requirements resume January 1, 2026. So stay tuned for that, because that will go into effect. These are our qualified behavioral health visits. This is on the qualified visit list. Remember, our qualifying visit list still has not been updated since 2016. So I just had a question over the weekend. Hey, I'm looking at this qualifying visit list, and it's just from 2016. It's almost 10 years old now. Is there a 2025 qualified visit list? No, there's not. MACs stick pretty strictly to the qualifying visit list, even though it's this old. And these are our behavioral health visits that we're allowed to bill as encounters for Medicare patients. Remember, we're talking about Medicare when we talk about telehealth. States have 50 different ways that they're doing telehealth. Some states have made permanent telehealth and encounters. Some states follow Medicare. Other states still have the old originating distance site requirements involved. So this is for Medicare that I'm talking about right now. Your state Medicaid plan may be different. Kentucky's a great example. Kentucky, an encounter via audiovisual with a qualified provider is an encounter. Illinois, we have some kind of complexity. So make sure to recognize we're talking about Medicare here with G2025. That does not apply to Medicaid, and behavioral health visits as qualified telehealth visits are also relative to Medicare. We have an in-person behavioral health visit, one of those on the qualifying visit list. We report that with a CG modifier. Report that with a CG modifier. If we have behavioral health via telehealth, we still use the CG modifier. This first one is audio visual. We use a 95 modifier. Audio only, telephone only, we still use the CG modifier, but we use an FQ or a 93 modifier. So we're going to tell Medicare how exactly this visit occurred, even though these behavioral health visits are encounters. And remember, we're going to have in-person visit requirements starting January 1. We do have the flexibility with this in-person visit requirement to say, hey, if the patient can't get to your clinic, if it represents a hardship for them to come in person, or if it puts their behavioral health at risk because of the hardship that presents to come in, we can still maintain audio only. But of course, we would expect that, we could waive the in-person visit requirement, but we would need to document, hey, this person, it represents a hardship to come in. We're maintaining telehealth only. And so just stay tuned for the rules around in-person behavioral health to either evolve or just go into effect. And also stay tuned for clinical visits. And if that just get kicked down the road one more time with G2025, or we do something more permanent with it, stay tuned. One of our biggest changes for this year is with care management services. The first of these big changes is that we see right here on this title slide, the G0511 has become unbundled. This was not put into effect until July 1. I believe this also got an extension to give some folks some more time, maybe to September 30th for G0511 to continue being billed, because actually a lot of us were having big trouble with our billing systems to be able to build out the CPT detail in place of the G0511. I won't mention the system, but it's a widely distributed, very expensive hospital system. I'll bet you know what I'm talking about. That I had 32 people on a call to unbundle the G0511 codes. 32 people on a call to unbundle these codes. So, we had people from revenue cycle, we have people from who does the fee schedule, we have people from practice manager, whatever. We had a bunch of people. So a lot of us have had significant difficulty unbundling G0511. What does that mean, unbundling G0511? First, remember, anything that happens with care management was just reported under this catch-all code. And we did not have transparency for the services that were being rendered. Hey, if I'm doing care management with the physician, I think I'm not going to guess which code that is. I don't have that right embedded in my mind. But we did not have an ability to report the actual services being rendered as care management services. We didn't have any ability to track the services that were being rendered, and we did not have the ability to add time-based add-on codes when we were using G0511. So while we can still bill for right now, I think it's extended through September 30. We can still bill the G0511. It's costing us a lot of money if we do that. This is language directly from CMS. So CMS said we're proposing, and we've now enacted, that RHCs can bill individual codes that make up general care management services. We're going to unbundle these codes. We're going to bill the individual CPT codes. We're allowing facilities through now September 30 to still bill G0511. However, those of us who were ready, we can start billing the detail instead of the G0511, but we can't bill both. It's one or the other. We either bill G0511 or we can bill the actual detail, not both. There was an effort to waive or request to waive co-payment for co-insurance for care management codes, because a lot of us recognize that it's a hardship for our patients and really a big barrier to getting consent to enter a care management program. We specifically, as part of our service requirement, have to inform our patients that there is a co-insurance, and we have to document that we've informed them and they've accepted that co-insurance. It often comes down to the provider saying, hey, you need this. We need to put you on care management services. Your co-insurance in the clinic is a lot less expensive than your hospital co-insurance. However, Medicare, CMS said, we do not have the statutory authority to waive co-insurance. They could not do that, but they said, make sure and provide information to your patients about availability of assistance program. We don't like to use the word charity because patients don't really want charity, but we can implement discount programs, assistance to help with cost sharing obligations. Now that is a whole other presentation of what we can do to write off co-insurance, because we can't just arbitrarily do that. We need to be able to provide financial assistance where it's applicable, but we do have the ability to do that. And it's not just with a sliding fee scale per Health Resources Services Administration. It's a totally different sliding fee scale requirement if you're in the loan repayment program, but we can have quote unquote charity care financial assistance to help people that don't have a secondary with their co-insurance amount. Now, here's the problem. We're about to see that we've added a bunch of new codes. And remember, just like telehealth, this is that G0511 is the average of all of the available care management services. It's the national average of all fee schedule payments for 2025. There's a big reduction down to $54 for G0511. So all of a sudden, we've lost about 30% of the allowable for our G0511 payment. So there's a big financial incentive to start billing all of the actual CPT codes that comprise our care management services. This is on the CMS Rural Health Clinic Center. You can pull this down right now. This is calendar year 2025. And when we look over here, the order is a little out of whack. Care management, 99490, $60.49. That's fifth from the bottom. If we have chronic care management for staff, each additional 20 minutes, an additional $45.93, how many of our care management services that we're providing are we able to bill the additional 20 minutes for? Most of them, from our experience. So if we're stuck in G0511, so all of a sudden we've gone from $54 to $60 plus 45, $105. We're losing a lot of money if we still bill G0511. Look at 99490, or excuse me, 99491, third from the bottom there. Care management by a physician, $82. Additional 30 minutes. Care management by each additional 30 minutes for the physician, another $57. So if we're only able to report one G0511 for that, we're foregoing a lot of revenue. It's a big deal. Look at G0511 there at the bottom, $54.67. Now our G0512, which is psychiatric coordination of care, $139. That is still in place. G0512 is not going away. We can still bill that. It's a different elevated care management time requirement, and it's psychiatric coordination of care. It's different. Most of our care management stuff is for clinical diagnoses. But G0512 is still in effect. G0511 is going away, and it's much to your financial benefit to stop billing G0511 and start billing the actual codes. Now, here are our remote monitoring codes that are now in effect January 1. So we can bill the individual codes, not just the G0511. And I can tell you, remote monitoring is a fantastic benefit to patients. Remote monitoring is an excellent source of revenue for the clinic, because so many of our patients need it. And this is another service that we can bill Medicare for as rural health clinics. Prior to 2025, remote monitoring was just an additional G0511. Most often with remote monitoring, there are probably 3 to 5 additional line items that you can bill for remote monitoring. What's remote monitoring? It's a blood pressure cuff that you send home that reports data back. It's a scale that patients weigh themselves and reports back. It's an A1C monitor that monitors A1C, monitors blood glucose, and reports back. And now we have a nice source of revenue. Oh, and our patients typically very much need this. And if you're in an ACO, it's a highly beneficial service to be providing and monitoring your patients with. So when we look at some claim examples, look at G0511 5471, physician time 20 minutes, 82. So we're 30% over now what we've been able to bill with G0511, and look at the pickup for the additional time when we're doing the additional 30 minutes. So think of time that our physicians may spend not providing direct care to the patients, but if we're billing this 99491 for a physician, we're anticipating the physician is providing this. So, hey, the physician's the one on the phone trying to set up a referral or get a report from a specialist. It's clinical activity related to that patient care, but not necessarily a face-to-face visit. And it's the same with if it's staff time. This is not administrative time for the staff setting up appointments, but a clinical person coordinating a referral with a specialist is absolutely time that we can document towards our care management services. It's really any clinical activity related to that patient care that we're not able to bill for. It's very broadly defined. It is clinical personnel. It's not reception or admin time, just setting up appointments. And where we see a timestamp, it is a requirement that we're documenting the time. Oh, I spent from 12:05 on August 12th through 12:55 on the phone trying to get this prior authorization approved with the medical director of this payer. So it's an important way to get paid. Think of it as an important way to get paid for the services that you're not able to bill for. And yes, there is a coinsurance on this, a 20% coinsurance. Most secondaries are picking the coinsurance up. It's really our patients that don't have a secondary that we need to provide some assistance to. Where do you go to get those rates? Hopefully you're familiar with the CMS Rural Health Center. This is the top header of that website. And right at the bottom of that first blue box, when you pull up the website, is down here at the lower left of my screen, highlighted as payment rates. You go select that payment rate link, and then you get this link right here. It will pull a .zip file to your computer that then you extract. So sometimes you click that link and you don't know what happened. Go look in your downloads and you've pulled this up, this .zip file, and it has an Excel document in there that has all of the list of fees that I just showed you. The G205 2025 is $96 for 2025. That G05, oh, excuse me, that was for 2024. We see effective March 3rd through December 31st, 2024. Those rates have changed. And we also have advanced primary care management services that we can now report. So just think back to what I just said about how much time we spend just documenting time. So these new advanced primary care service codes are based on patient risk. They're not based on time. We eliminate time. So CMS recognized, hey, we want to find a way for rural health clinics to receive separate payment for advanced primary care management based on the complexity of our patient's condition, not time-based. We want to simplify billing documentation requirements with these. So these are just per calendar month. We can bill each of these for patients that have particular levels of risk. Those levels of risk are different and our payment is different if we have qualified Medicare beneficiary, which is primarily a dual eligible, where Medicaid is picking up the cost of participating in Medicaid for that patient. So our most at-risk, poorest patients are typically our qualified Medicare beneficiaries, and there is a big payment differential for them. So the risk differential is, I'm going to say something that's unrelated here in a second. Patients with one chronic condition is probably a healthy patient for a lot of us. And how many of our Medicare patients have one chronic condition? Almost all. How many of our Medicare patients have more than one chronic condition, two or more chronic conditions? I remember when care management services first came out and we thought, oh, two chronic conditions, a healthy patient for a Medicare patient. But notice what's not on here is time. We do not have to document the amount of time that we spend with these patients for non-face-to-face services. Again, time on the phone coordinating a referral, time on the phone coordinating a community health resource, time on the phone identifying, any number of things we can think about. Now, the payment is not enormous until we get down to the qualified Medicare beneficiary book. A payment is double. Qualified Medicare beneficiary with two or more chronic conditions, there's not a time constraint on it. It's $107 for this year. So that is a big new benefit that I find very interesting. Now, what I was about to say is, and I don't have in this presentation, evaluation and management services are now based on medical decision-making and or time. Evaluation and management services are 99213 versus 214, or 99203 versus 204. Remember not so long ago when we were having to count bullet points to determine bullet points and how many systems determine the level of service we report? It's all gone away. Evaluation and management levels of service are now based primarily on medical decision-making. Moderate medical decision-making, one of the criteria is two or more chronic conditions. Moderate medical decision-making, if a patient has two or more chronic conditions and one has exacerbated, it's moderate medical decision-making. Two or more chronic conditions and another set of symptoms have presented themselves, moderate, maybe high medical decision-making. 99213, low medical decision-making, is somebody with no chronic condition, and they present with an acute problem-focused symptom. Is that our Medicare patients? No. Most of our Medicare patients, when you read the description for moderate medical decision-making, focus on those two or more chronic conditions. So that means if you're billing a lot of 99213s for your Medicare patients, you're probably undercoding. So think about your patients with two or more chronic conditions, A, if they qualify for advanced primary care management and what level of service. But this also has this moderate, two or more chronic conditions, has a big impact on your level of service you're reporting. So if you're still reporting a lot of 99213s, again, not necessarily related to any new RHC updates, but I've really been harping on everyone, hey, where's your evaluation and management utilization? Because it corresponds directly to this degree of risk with your patients. Time is another factor. That's a whole other presentation, but I'd be remiss not to bring that up. Goes directly into our add-on codes. Big question. Hey, can I get paid? Does rural health pay? That's the bigger. This is the one I always get. Does rural health pay for GT 2211? Additional time spent counseling the patient. It's kind of a trick question. Is it reportable? Yes. Can we put it on our claim? Yes. Does rural health pay more? No, not really. But we put this on as an add-on code, like an incident to service with our evaluation and management services. So first of all, yes, now we can bill G2211 complexity inherent to evaluation management associated with medical care that are related to ongoing serious conditions or complex conditions the patient has. We can bill G2211. We bundle it just like an incident to service. It's not a big add-on. So I came up with $30 as a sample fee for a G2211. I just took the Medicare allowable and doubled it. And then when we bundle G2211, it's X, just like an incident to service. And what are we going to get out of that? Coinsurance. This will impact the patient's coinsurance. But every source of revenue counts right now. And yes, that will typically, most of our patients have Medicaid secondary, the dual eligible, or they have a supplement. And one would not anticipate we're billing a lot of G2211s with a 99213. We're already spending more time with the patient. We've maxed out our time on our evaluation and management service, and there was prolonged counseling required for this patient. So it doesn't prompt an additional Medicare payment, but it does increase revenue, and it is now billable and reportable in exactly the same way that injections, administration of an injection, or other incident to services are reported as a rural health clinic. And again, by implication, these are for higher levels of evaluation and management services. Social determinants of health is the gateway for community health workers. Gateway for community health workers, G0136. And we can now bill these with preventive service if we've gone to deliver or make a determination that this patient has social determinants of health risk. Social determinants of health are meant to evaluate whether the patient has transportation security risk, food security, housing security, utilities, whether or not they can keep the power on. This is the gateway to other care management services. Community health workers are now payable. Part of our care management services are community health worker interventions. One of the biggest questions I get, can we bill an annual wellness visit at the same time as a sick visit? Yes. Does the annual wellness visit at the same time as a sick visit get paid as an encounter? No. It's a standalone encounter. A standalone encounter means when performed with another qualified visit, there's only one encounter paid. So what's the difference? Why would I do that? Any of you participating in ACOs need to know you can report an annual wellness visit at the same time as a sick visit. With a couple big notes on here. First of all, look over here. We are not bundling the annual wellness visit into the sick visit CG modifier. If we bundled any of our preventive services up into that evaluation and management service, what would happen? Trick question. If we bundled an annual wellness visit with our CG modifier sick visit, patient will get co-insurance on the preventive visits if we cannot do that. If we're bundling, if we're billing this correctly, look at the RVU differential we're creating. 6.2 RVUs when we're going through all of the steps of an annual wellness visit, advanced care planning, and social determinant of health. If you're in an ACO, this makes a big difference. No, it's not more direct revenue. But what happens if in the case where we say, oh no, when we erroneously say we cannot report an annual wellness visit on the same day as a sick visit, the patient, you should just come back for that. First of all, Medicare does not like that. Why do we have social determinants of health? Because of transportation security. Is the patient going to come back for an annual wellness visit or preventive visit? No, they're not going to come back for that. We have a hard enough time getting them in when they're very sick. So we need to treat the patient while they're there. This billing like this with the 214 first, with the CG modifier, there will be a coinsurance, but it'll only be based on the evaluation and management service. So this is how to bill. Will not result in any additional reimbursement, but you'll get credit for the annual wellness visit. So those of you in ACOs, it's very important we start to embrace that we can bill this way. Now, how about the patient that comes in? We've called, we said, hey, you need to come in for an annual wellness visit because we're in an ACO. So we're calling all of our attributed patients. Come in for your annual wellness visit. And then the patient comes in and we do the annual wellness visit and somebody's told us, oh no, we can only bill this way, which is incorrect. The patient's going to get mad because they thought they're coming in for an annual wellness and preventive visit and there's no cost to the patient. We have a solution. This is perfectly legitimate. Same thing happens here. Look what's first. Annual wellness visit is first. CG modifier, $240. We haven't bundled any line items, but the patient's sick and they're here now, and we need to treat them for their chronic illnesses beyond just the annual wellness visit. This is perfectly acceptable billing method. We are not bundling anything. There's not going to be a co-insurance on this. So the 214 is for information purposes. But if you're on an RVU, your provider's on an RVU, you're going to come out all right on this. Your hospital, your CFO may not like it a lot. How do I know we can do this? Well, first of all, because when you go look at the Medicare FAQ, CG billing FAQ, it says we can make a determination that the preventive visit was the majority reason for the visit. We can bill this way. We can bill this way. How do I make the decision? Well, your provider makes the decision. What I like to say is, if the patient was called to come in for their annual wellness visit, and that was the primary reason for the visit, have the provider select the codes in this order. If your provider, nurse practitioner, or doc, is the one doing the entirety of the annual wellness visit and advanced care planning, social determinants of health, it is not going to get done. So we can bill subsequent annual wellness visits from a nurse just like this. Say this was a subsequent annual wellness visit and the nurse did the whole thing, we can report it. Of course, we cannot report a subsequent annual wellness visit performed only by the nurse as an encounter. But if there's already an encounter, we can bill it. We can report it. There's not going to be a difference in reimbursement, but we get credit for it with the ACO. And oh, by the way, for Medicare Advantage, bill every line item possible. Because we come out well on our Medicare Advantage programs when we're billing the line items this way. And then the Medicare Advantage has their own quality programs that you're going to start doing a lot better on when you start billing this way, as opposed to, oh no, we can't bill this together. The patient needs to come back. They're not coming back. You already know this because you've done it. You've seen it. These two methods are perfectly acceptable. And when somebody says they're not, tell them with all due respect, they are. We can bill this way because it's in RHC FAQ and bill everything possible to Medicare Advantage, and they will pay you for them. Whew. Covered a lot of territory there. And that also goes directly to all of our CPT2 codes. What also gets reported with all those annual wellness visits? Well, how's the patient's A1C? Is it greater than 9%? There's a CPT2 HCPCS code for it. Did the patient report a mammogram result within the last 15 months? It can be verbally reported if they know what the result was and approximately when it was. There's a CPT2 code that we can fire. What was the result of the depression screening that we did? Did we need further counseling? There's a CPT2 code. Why would you report your CPT2 codes? Because you're in an ACO. And we need to be able to report those. I may know the guy who is breathing heavily down everybody's neck that we could bill CPT2 codes on our UB04. He's in the room. And a lot of us were clamoring for, we need CPT2 codes on our UB04. And now, effective April 1, we can do it. Before April, what a lot of us didn't understand is we could bill our CPT2 codes on a 1500, and I think you probably still can, but don't quote me on that, because now we don't have to split bill them anymore. Now, after April 1, we can bill CPT2 codes per this change request on our UB04. We would report them as a penny. Line items on our UB04 have to be greater than 0. So we can report them with a penny. And again, Medicare Advantage, it will behoove you to report all these to Medicare Advantage. And if you're having, I think, sorry, when I just last updated this, a lot of the CPT2 codes were creating problems on our UB04. So while you're working it out with your Mac, I believe you can still get them on a 1500. But just know CPT2 codes are billable on a 1500 as 1 cent, and now on your UB04 as 1 cent. You no longer have to split bill those. So that's a big deal. An enormous change for all of us in rural health clinics has been now the ability to bill and how we get paid for preventive vaccinations. Pneumo, influenza, COVID, and Hep B vaccinations. We had to wait until the cost report settled to get paid for those. We're supposed to get paid 100% of our cost for these vaccinations is the reason we put them on the cost report. Because if we didn't put them on the cost report, first of all, the claimant would get paid. But secondly, we didn't get 100% reimbursement. And per the statute, the rural health clinic statute, we're supposed to get 100% of our reasonable cost for those services. So now we can bill these on our UBO4. We can bill these at the time of service, but we're still going to get a cost reconciliation with those. So there's still going to be a cost reporting impact. So now you can bill these. I'm not exactly sure. We just had this go into effect, and a lot of us were having problems with the claims. And yes, we still need to report these on our cost report. So don't do away, if we're billing them, we should be able to pull a log to submit with the cost report. So don't do away with that. There will be an annual reconciliation so we get 100% of our vaccination cost. So make sure you can start billing those. We don't have to wait till next October. Cost report's not due till May. Cost report doesn't finalize till next fall. We don't have to wait a year for our reimbursement. So that's a big deal. Another big deal is that our productivity standards on the cost report have been eliminated. Productivity standards are gone. It used to be 4,200 for physician, 2,100 visits for nurse practitioner PA. Now we don't have to. Now that's not a thing. But that doesn't mean you shouldn't be tracking your productivity. It just means there's not a cost report impact when you don't meet that per FTE productivity requirement. So those have been removed as of last year's cost report. 2024's cost report. We submitted it this year, but it was for 2024. Conditions for coverage also changed. Remember, we had this primarily engaged in primary care services, which if we had behavioral health and specialists, we had this 49%. We couldn't be more than 49% behavioral health or specialty. And that was kind of gleaned from the air in the state operations manual. And now CMS is no longer going to look at if your specialty services outweigh your primary care services. As long as you're providing primary care services, you're not going to be cited during your survey. But CMS is requiring we still cannot be more than 49% behavioral health. Remember that first slide at the beginning. Cannot be primarily behavioral health, treatment of behavioral health diseases. That's still part of the statute. And CMS is looking at that. It's where we have behavioral health and other specialty services that push us over that 49%. So the big thing is if you have a lot of behavioral health in your clinic, make sure you're seeing the patient as a primary care visit and treating all of their conditions. Make sure we're documenting that we're seeing the patient for more than just their psychiatric conditions. And you do have to continue to ensure that we're not more than 49% behavioral health. CMS is surveying for that. There was another proposal to define behavioral health services differently, and that proposal was withdrawn. Couldn't do that, but they're at least not surveying or at least not applying specialty services more than 49% as long as we're providing primary care services. Hematocrit, Hemocult, what did I say? Hemoglobin, hematocrit, occult blood, primary culturing now removed from our conditions of participation. We do not have to provide hematocrit, occult blood. You don't have to do that any longer. They had proposed, doing away with the primary culturing. And did we revise that? Yes, they did. But the big ones are the occult blood and hematocrit. So we don't have to supply those tests and not use them anymore. So a lot of big changes for 2025. Here are the rules and where you can find the source documents there. And as always, these are our references. One I do not have in here is just use your Googler, RHC QVL or RHC CG QVL, and you'll get that FAQ. Excuse me, I said QVL. RHC FAQ, CG modifier FAQ, that has the guidance that I talked about, the annual wellness visits and the sick visits on the same day. So we've covered a lot of territory. That's how to get a hold of me. I'm sure Melissa will distribute these slides, send them to her.
Nope.
Feel free to reach out to me with any questions you have about any of this material.
All right. Yes, I will. Thank you, Charles. I'll be sending that out to everybody. And thank you again for your wealth of information and knowledge. That is a lot to absorb. So, of course, I'll be sending those slides. We have a couple minutes left. Are you okay with answering some
Of course.
questions?
Of course.
So upon registration, we had a couple that had came in, but I think there's one here that I'd like to address that you did answer, but specific to billing vaccines, they wanted to know, how do we bill vaccines to Medicare Part B, or is it supposed to go to Part A on a UB, or do we bill it separately? So I did hear you mention that to put that on a UB, but if you want to go into specifics there.
It does have to go on it does go on a UB04. We're not going to split bill that. I think there are a couple of condition or occurrence codes that go on those. And I don't have those off the top of my head. I can look those up and send those to Melissa, but they're definitely going to go on your UB. I think it's an A6.
Yeah, I think you're right. I think it's like 636 and 771 maybe, but yes, absolutely. We'll get those to you, to everybody and attendees also. I know some of you are grouping up in rooms, but anybody that registered, they will get this information.
Melissa's exactly right. The revenue code is 636 for the medication, and the 771 is the administration, I believe. But those will be line items on your UB04. Correct.
Let's see. How about a strategy question that came through? How should RHC leadership prioritize implementing these updates across their team?
Well, the first thing to do is check with your practice management system, particularly on the codes, and make sure that your practice management system is not going to have a problem. You know, some systems you have to go rewrite your rule. Again, on the other system, just to get the codes unbundled. So check with your practice management vendor, make sure you can unbundle those codes. Then make sure that you're appropriately documenting time on care management. Documenting time on care management is a hard stop. If there is a time requirement on any of these, thinking tobacco cessation has 5 minutes. Someone will say, well, 5 minutes on documenting, on doing tobacco cessation counseling is not realistic. It takes 2. But still, if there's a time-based requirement, you've got to have that in the documentation. So practice management vendor, how are you documenting? Are you capturing the time? And then is there an ability to go ahead and do the advanced primary care management services? So you're definitely going to have some team meetings to determine that you have all the tools that you can to submit those. And then make sure and test them. Don't run out and do 500 line items at once. Do 5 line items at once and test, for example, on any of these. Test to make sure the claims go through. And then once they do and they're being paid appropriately, go ahead and submit in bulk. So practice management, provider documentation, who's doing the work? If it's not just providers, what clinical staff is doing the work, and are they appropriately documenting the time? And then testing the claims before you go fully live with it is very important. Same with all of the vaccinations. Test a few of those vaccination claims and then start submitting them in whole once you've successfully tested them.
Perfect. Perfect. Thank you for that strategy. We have hit 101, so we're just slightly over. So we'll go ahead and wrap this up. And again, thank you, Charles, and everybody else. We will be sending this out.
Thanks a lot.
Thank you.
Thanks for inviting me.
Absolutely. Bye bye.